Welcome to the Stroke Care and Treatment Protocol for 2015. Today's training is to go over the new RACE stroke scale assessment and the changes that have been made to the treatment protocol. To begin, let's talk about the different types of strokes. The two types are ischemic strokes and hemorrhagic strokes. With ischemic strokes, there are two different causes. One is embolotic, which is an occlusion of the artery caused by an embolus, whether it's a solid, liquid, or gaseous mass, that is carried through the blood vessels from another area of the body. The most common cause of emboli is blood clots. The second cause of an ischemic stroke is thrombotic. This is the result of plaque deposits that build up in the interior cerebral arteries. A plaque gets roughened and it creates the reaction where a blood clot is then created at that area and it obstructs the artery. With hemorrhagic strokes, there are two different locations that the bleeding can occur: intracerebral hemorrhaging, or bleeding within the brain, and subarachnoid hemorrhaging, or bleeding within the subarachnoid space. Intracerebral hemorrhaging is most often caused by hypertension, which causes the blood vessels to rupture. With subarachnoid, the most often cause is congenital blood vessel abnormalities like an aneurysm. The only way to definitively determine whether or not the patient is having an ischemic stroke or a hemorrhagic stroke is to perform a CT scan at the hospital. This is important because the therapy utilized for ischemic strokes, which is thrombolytic therapy, cannot be utilized with a hemorrhagic stroke. When they take the image of the brain, they're looking for two different things. They're looking for the infarct, or the tissue that is permanently damaged by the lack of blood flow. They're also looking for what we call the penumbra. This is an area of salvageable tissue that has been surviving due to collateral circulation. There are two different types of neuroimaging that is currently being utilized that will allow the doctors to see this infarct and penumbra area. That is the perfusion-weighted imaging, or PWI, and diffusion-weighted imaging, or DWI. This new neuroimaging equipment allows doctors to be able to determine whether or not there is any salvageable area brain, or any area that has a large enough penumbra to go ahead and reperfuse. It is because of this information that the time criteria has been removed from identifying a stroke alert. The symptoms for the stroke patients are going to vary because it depends on what area of the brain is being impacted and how large that area is. So we're going to go ahead and break down this next part based on what area of the brain is being impacted. First area we're going to talk about is right hemispheric strokes. Typical symptoms that you're going to see with an area affecting the right hemispheric is slurred speech or dysarthria. You'll also see weakness or numbness to the left side of the face, arms, or legs. And they'll also have a right gaze preference. Symptoms of a left hemispheric stroke can be seen with aphasia. Aphasia can be either expressive or receptive. Expressive aphasia is the inability to get the words out correctly, and receptive is the inability to hear the words correctly. They may have weakness on the right side of the face, arms, or legs, and left gaze preference. Symptoms of a brainstem stroke can be nausea and vomiting, vertigo, speech problems, swallowing problems, abnormal eye movements, and decreased consciousness. Symptoms of an intracerebral hemorrhage can be nausea and vomiting, headache, one-sided weakness, or a decrease in consciousness. And finally, symptoms of a subarachnoid hemorrhage would be the worst headache of life, intolerance to light, or neck stiffness and pain. As you're assessing your patient, do keep in mind that some conditions do mimic stroke symptoms. Some of those conditions are hypoglycemia, certain drug overdoses and toxicities, alcohol intoxication, hypoxia, seizures, cerebral infections, migraines, brain tumors, Bell's palsy, and hypertensive encephalopathy. So let's begin to talk about the new stroke protocol. And the first aspect we need to discuss is, when do we call a stroke alert? We're going to be calling stroke alerts based on the RACE scale, or paramedic judgment. We're utilizing the RACE scale, or the rapid arterial occlusion evaluation, because it's been shown in studies to be able to determine a large vessel occlusion with an 85% accuracy when the score is 5 or greater. This information and the scoring system from this scale is going to be a very helpful tool for the neural interventionalists, for them evaluating whether or not to begin parallel interventions while you're en route to the hospital. However, the RACE scale does not cover all of the aspects or all of the symptoms of somebody having a stroke. So in this case, paramedic judgment has been added so that these other symptoms and that other experience and knowledge level that you have in identifying somebody that has a stroke can be called a stroke alert. And the last aspect that has been added to the inclusion criteria for identifying a stroke alert is making sure that the blood glucose level is greater than 60 milligrams per milliliter. This is important because hypoglycemia is one of the mimics for stroke symptoms. So now we're going to go ahead and show you how to perform a stroke assessment utilizing the RACE scale.
Hello, my name is Dr. Brijesh Mehta. I'm a neurointerventional surgeon at Memorial Healthcare. Today we're going to perform the RACE scale, which is a term for Rapid Arterial Occlusion Evaluation. And for EMS personnel, it's very useful as a pre-hospital predictor for a large vessel occlusion in a stroke patient. So we will demonstrate each of the individual components of the RACE scale, specifically facial palsy, arm strength, leg strength, gaze or head deviation, speech problems, and agnosia or neglect. The first component of the RACE scale is facial symmetry or asymmetry, and there we're evaluating for the strength on each side of the face and looking for any weakness. So we ask the patient if they can smile simply, and if they're able to do that and it looks symmetric, then that's no deficit, meaning 0 points. So this is evaluation of facial asymmetry. I've asked the patient to show me a smile, and you can also ask patients to show us their teeth, and as long as they're able to attempt to activate both sides of the face, you can appreciate any asymmetry. So here there's a moderate asymmetry between the left and the right side. You can appreciate the slight crease in the face called a nasolabial fold, and therefore this would be a moderate weakness in the face, or 1 point. So in this situation, I've asked the patient to smile, and you can now appreciate that there's severe weakness in the left side of the face with absence of the nasolabial fold or the facial crease, and droopiness of the face that is more prominent than the moderate weakness. And therefore we would grade this as 2 points with severe weakness of the face on the left side. Next component of the RACE scale is arm function, meaning arm strength. And in those situations, we ask the patient to lift up both arms anti-gravity as if they're holding a tray with the palms up. And as long as we don't appreciate any asymmetry in the strength of the arms, meaning that there's no drift of one arm versus the other, we grade this a completely normal exam with 0 points for arm strength. So the next component of the RACE scale for arm function is to assess a patient who has weakness in the arm that is of moderate severity. And in that situation, I ask the patient to lift up both arms, anti-gravity, and then we note that the left arm is slightly weaker than the right arm, and as I start to count back from a full 10 seconds, he's not able to sustain the left arm anti-gravity that entire time. So 10, 9, 8, 7, 6, keep it up, 5, 4, 3, 2, 1. 0. And you see the left arm drops below the full 10-second count is up, and therefore the patient would get 1 point for moderate weakness, meaning he's able to lift the arm up, but cannot sustain an anti-gravity for the entire 10 seconds. The next phase of the arm strength evaluation is to assess for patients who have severe weakness. In those situations, we again ask the patient to attempt to lift up both arms, but he's unable to lift one arm off the bed at all, and therefore it receives 2 points for severe weakness, as in this situation. So go ahead and lift up both arms for me. Can you lift up your left arm at all? Up, 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 up. Okay, so you can see here that he's making attempts to lift the left arm up off the bed and is unable to do so. Any side-to-side movement in the plane of the bed, meaning not anti-gravity, but side-to-side motion with attempts, is still severe weakness. The patient has to get the arm fully off the bed, anti-gravity, for us to say this is only moderate weakness. If they cannot lift the arm up at all, then it qualifies as severe weakness. So therefore 2 points. Phase of the ray scale evaluation is to assess for leg strength. So in this situation, we ask the patient to lift up each leg individually and determine if there's any weakness. And if they're able to lift up each leg and keep it anti-gravity for a full 5 seconds, then it's 0 points, meaning no weakness. If either leg exhibits weakness that to a point where they cannot keep the leg up for a full 5-second count, then that's moderate weakness, 1 point. If they cannot lift the leg off the bed at all, then that's 2 points, meaning severe weakness. So this is a demonstration of a normal evaluation for leg strength. I'm going to ask him to lift his right leg and count down 5, 4, 3, 2, 1, 0. And so he has normal strength on the right side, so that's 0 points. And just to make sure that there's no weakness on the left side, ask him to lift the left leg up and count down 5, 4, 3, 2, 1, 0. Perfect. So that's 0 points for leg strength, meaning there's no weakness. To lift up, in this situation, one leg at a time, and if they cannot lift up the leg anti-gravity, and this phase for a full 5 seconds, then it is considered moderate to severe weakness. Moderate weakness if they lift it up, but then it drops to the bed before the full 5-second count is up. And so go ahead and lift up the right leg for me, sir. And I will count down from 5, 4, 3, 2, 1. So go ahead and lift the left leg up for me. And 5, 4, 3, and before the count is up, the leg is dropped. 2, 1, 0. So with assessment of the leg function, there can also be severe leg weakness, and that's graded as 2 points. In that circumstance, the patient has a weakness that's bad enough that they're unable to lift the leg off the bed at all, and they may have some side-to-side movement. However, that does not count as part of the strength assessment. They have to be able to get the leg off the bed in order to count it as any type of strength. And therefore, 2 points would be unable to lift the leg off the bed at all. And so in this situation, the patient has severe weakness. I ask them to lift the leg up. Can you lift the leg up? Up, 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 up. And they're unable to get the foot off the bed, and you can readily assess the heel also as a sure sign that they're indeed not able to lift the leg off the bed. And the side-to-side movement, that does not count as part of strength, so this patient would get 2 points for severe leg weakness. So the next component of the ray scale is to assess for head or gaze deviation with the eyes. And what that means is we're looking for any sign of the patient's head just looking towards one side or the eyes forced towards one side. And this is concerning because in a middle cerebral artery stroke, if there's a clot in the artery, generally the patient looks towards the site of the vessel occlusion. So if it's a right middle cerebral artery stroke, for example, and it's a clot dislodged within the large caliber vessel like that, the eyes will be deviated to the right side towards the stroke as well as the head. So presence of any head or gaze deviation towards one side, the patient would score 1 point. Absence of head or gaze deviation would score 0 points. If the patient is looking straight and on prompting they're able to look towards the examiner, towards me, and then they're able to look in the other direction and back and forth without any issues, then that would be 0 points as a normal assessment. If the gaze or head are deviated to one side and they're not able to cross midline on prompting to the other side, then you would score that as 1 point for presence of head or gaze deviation. So in this situation, when I look at the patient, I observe that the head is deviated and it looks like it's force deviated to the right. The eyes are also deviated to the right. So my first question after the observation is, can you look to your left? Can you look at me? And if they're unable to do that, then you score that as 1 point. So, sir, can you look to me? Look towards me. Can you bring your eyes over here? Can you follow my finger with your eyes? Can you look this way? And when I turn the head, it's essentially flexed towards the right side. And I would generally not recommend, if the patient's found down on the floor and they have concern for cervical spine injury, to do any neck manipulation. In that situation, just make an observation of the gaze and the head deviation. And therefore, the patient would get 1 for presence of the head and gaze deviation to the right. So the next component of the Ray scale is to assess for aphasia, which means ability to follow commands. The language function in most patients is on the left side of the brain. And therefore, if the patient has right-sided weakness, those are the situations when we want to assess for aphasia. The 2 simple commands in the Ray scale that we ask the patient to perform on the good side, which is the left side of the body, is make a fist and close eyes. So here in this situation, we have a patient and we want to assess for aphasia. I will ask the patient to perform these tasks on the left side. So make a fist and now close eyes. Great. So in this situation, we would score this as 0 for aphasia because the patient got both the first command, making a fist, as well as the second command, closing eyes, correctly, and therefore no deficit on the aphasia component. So to demonstrate a abnormal component for aphasia, so I will ask the patient to go ahead and make a fist, and he's able to do that correctly. And now close eyes. And to command, he's not able to close his eyes, and therefore he got 1 task correct. However, 1 task he's not able to execute properly, and therefore we score this as 1 point on the Ray scale for moderate aphasia. Now, to assess for severe aphasia, we again ask the patient to follow the 2 simple commands as demonstrated earlier. And so here again, I ask the patient, can you go ahead and make a fist for me, sir? Go ahead and make a fist. And can you close your eyes? Close your eyes. Keep them closed. And you can see here that he's not able to follow either of those commands, and therefore will score 2 points on the Ray scale for inability to follow 2 simple commands, and therefore severe aphasia. The final component of the Ray scale is to assess for ability to recognize one's arm as well as recognize any impairment, weakness, disability in one's arm. And therefore, you want to focus on the side that they have the weakness. And in this demonstration, the patient is noted to be weak on the left side. And therefore, the first question would be, do you feel any weakness on this side, and whose arm is this? And if they get both of those questions correct, and you score that as 0, that means they do not have any agnosia, meaning no asomatoagnosia, no anosagnosia. Asomatoagnosia, meaning they are unable to recognize this as their arm, and anosagnosia, meaning they're unable to recognize anything wrong with the arm, such as no weakness or disability. And 1 point for moderate agnosia means that either of those prompts with the questions is incorrect. So they either cannot tell that this is their arm, or they're denying, unaware of any weakness on that arm. And severe agnosia means they are unable to recognize this as their arm, as well as they deny that anything's wrong with it. They feel like they have full strength. And so that's 2 points. So we've noted that the patient is weak on the left side, and therefore I hold up this arm and ask, do you know whose arm this is?
Yes, it's my arm.
Do you feel any weakness in this arm?
Yes, I do.
Okay. And then when I let go, note that the arm just drops. And so he got both of those questions correct, and therefore he has no agnosia and a score of 0. After noting that patient's weak on the left side, I lift up the arm and say, sir, whose arm is this?
I don't know.
So he does not recognize that this is his arm, so he has asomatoagnosia. Then I ask, do you feel weak in this arm?
I don't know.
Do you feel weak at all?
Yes.
Okay. So therefore, he gets 1 point because of asomatoagnosia. He does not recognize his arm. However, he does recognize that there is some weakness, and so he does not have anosagnosia. And we would term this as moderate agnosia. And we've again noted that the left side is weak, so I'm going to hold the arm up for the patient and ask, sir, whose arm is this?
I don't know.
Okay. Is this your arm?
No.
Okay. Do you feel any weakness in this arm?
No.
Does it feel normal?
Yes.
Okay. And when I let go again, it falls down. So this patient has severe agnosia, meaning he's unable to recognize his own limb, as well as he denies that he has anything wrong on that side. And therefore, he has asomatoagnosia as well as anosagnosia, and we score at 2 points for severe agnosia. So we want to make a note that as part of the race scale assessment, if you add up all the points for the individual components that are tested, then you will get 11 points. However, note that the race scale is only 0 to 9 points, and that is because in patients, when they're noted to have weakness on the right side, you're only testing for the aphasia component, and when you have weakness on the left side, you're only testing for the agnosia component. And therefore, the 2 points from one of these components will not be included based on which side that they have weakness on, and will result in a total of 9 points for the overall scoring.
The first step of the protocol under supportive care is to determine and document the time of onset of stroke symptoms. Though we are not utilizing the time of onset for determining a stroke alert, we still need to gather this information, and it's still important information for the neurointerventionalist. Next, you'll perform the RACE exam, and you'll go ahead and determine whether or not the patient meets any of these stroke alert criteria. If they meet a stroke alert criteria, then you'll go ahead and contact the closest comprehensive stroke center and identify that you have a stroke alert. One of the aspects to make note in this section, though, is that some agencies are using telemedicine or FaceTime. When you're utilizing video chat with a neural interventionist, make sure that you apply verbal consent from the family or from the patient prior to performing the telemedicine. Next, it's recommended that you position your patient in a supine position with their head elevated about 30 degrees, unless your patient cannot tolerate this position. Next is oxygen administration. This is going to be based on your SpO2 or your pulse ox information. If the SpO2 is greater than 94%, we do not need to administer oxygen to these patients. However, if it is less than 94%, you should begin administering oxygen with a nasal cannula. If you're unable to maintain 94% oxygen saturation, or if the patient is in respiratory distress, then proceed to either high flow O2 with an honorary breather or assistive ventilations with a bag valve mask if it's indicated. The first step in ALS Level 1 procedures is to establish a large bore IV. This is important because many of the procedures or interventions that are going to take place at the hospital are going to require the need for a large bore access. In addition, if 2 large bore IVs can be established, that would be a good practice as well too. Next is consider the need for assisted ventilation or an advanced airway. And the final aspect is perform a glucose test with a finger stick. If the blood glucose level is less than 60, depending upon your patient's condition, will depend upon what method of increasing your glucose level will be obtained. If the patient is conscious with a controllable airway, we can go ahead and administer oral glucose to our patient. If the patient is unable to control their airway, we can administer dextrose 50%, 25 grams slow IV. And finally, if our patient is unable to control our airway and we're unable to establish an IV, we can administer glucagon 1 milligram IM.